tough patient. It's a 68-year-old gentleman, and age is just a number, but sometimes it's an important number. So at the age of 68, our patients often come to us with other comorbidities, and they may not tolerate induction chemotherapy as well as their younger counterparts. And so one of the first things we're really assessing is the fitness of the patient. How active are they? Are they the kind of patient that's still working part-time, out on the golf course a few times a week, maybe still goes to the gym pretty regularly? Or is this a patient who has other comorbidities and spends most of the day in a chair, or maybe even is wheelchair bound? And this is really challenging because it's quite variable between physicians, and we haven't gotten good at kind of uniformly approaching the assessment of performance status. But the first thing we consider, is what does the patient look like that's sitting in front of us? And then also really importantly in a 68-year-old patient are what are their goals? Going through induction chemotherapy is not always easy, and even with induction chemotherapy and the improvements we've had in the recent years, their prognosis is still relatively poor. So I think having a realistic expectation of outcome and what that patient expects in terms of their quality of life and their personal preference is also important. But the first thing we're trying to decide is whether we want to do induction or more palliative therapy. For us at our institution, we consider transplant for all of our patients up to the age of 80. That being said, as we crest 65 and 68, those transplants get more and more difficult, and we certainly recognize that given patients' comorbidities, given their age, they may have more difficulty tolerating a transplant. But multiple studies have really shown that the incorporation of transplant into consolidation for patients in CR1, even over the age of 60, leads to the greatest improvement in their overall survival. So for us, when a patient walks in to my office as a leukemia physician, if they're fit and healthy and interested in proceeding with induction, my goal is absolutely to get that patient into a deep CR1, start evaluating for typing so that we can proceed to transplant when we have a remission. In terms of assessing remission, I think that as time has gone by, we've gotten better at being able to detect cancer cells, and the definition of remission continues to change. So now we talk about not only a morphologic remission, but a cytogenetic remission, a molecular remission, and then minimal residual disease testing, which can be a combination of either flow cytometry, next-gen sequencing, or even PCR. And so what we know for sure is that patients who achieve an MRD negative response and have no measurable residual disease have better outcomes in CR1 without a transplant. But even more importantly, these are patients who have better outcomes with a transplant. So a patient that we achieve an MRD negative remission in, we're even more optimistic as they proceed to transplant that they'll do well after the transplant also.